Thank you once again for inviting me here. And I'm aware that I'm standing between you and lunch. So I'll try to be as brief as possible. Well, most of the deliberations have happened over the last 2 days. But just an interesting aspect which I was reading while preparing for this presentation about early breast cancer and ISMO guidelines, the tumor, which is neoadjuvant chemotherapy, is recommended in people who have a tumor which is more than 2 centimeters. And the last line is particularly important: TNBC HER2 positive tumors more than 2 centimeters and or with positive axilla, regardless of feasibility of optimal surgery. So that is important, that it may feel that it can be operated, but they still should be subjected to neoadjuvant chemotherapy. And why so? Well, we all know it is standard of care in locally advanced disease. It helps achieve breast conserving surgery with good cosmesis. Chemotherapy is delivered when the vasculature is intact. It works as an in vivo marker of chemosensitivity. You can adapt your response to chemotherapy. And pathological complete response rate is a strong predictor of survival in triple negative breast cancer. Commonly used go-to regime is sequential anthrattaxins. All of us are familiar with that regime. All of us use that regime every now and then. Rarely, some of these patients also receive docetaxel and carboplatin. And this anthrattaxin gives us a PathCR of about 30 to 40%. We definitely need strategies to improve this PathCR rate, because if that is going to correlate with survival, we should have more and more patients achieving PathCR. So how do we try that? One is addition of another drug, that is carboplatin, addition of a biological drug based on a biomarker PARP inhibitor, and the last but not the least, immunotherapy. Addition of carboplatin, this was first attempted in JPAR 6 study. It was not a study for triple negative, it was study for all NACTs, but triple negatives were analyzed separately. Patients were given paclitaxel and non-pegylated liposomal doxorubicin with bevacizumab and carboplatin in the AUC of 1.5. They began with AUC of 2, then they dropped to AUC of 1.5. And the pathological complete response rate, as is seen by the columns, 36.9 months in the paclidoxo arm versus 53.2% in the arm which had carboplatin in it. 3-year disease-free survival also significantly better, 85.8% in the pacli-carbo arm versus pacli-carbo-doxo arm versus 76% in the pacli-doxo arm. So definitely good response, good pathological complete response, better DFS, but it also came at a cost. And whether it was related to BRCA or non-BRCA, it didn't matter. You had a BRCA mutation or a non-BRCA mutation, your carboplatin still worked. Main concern was toxicity. If you see the major hematological toxicity, anemia, neutropenia, febrile neutropenia, thrombocytopenia, all these were significantly higher in the group which received carboplatin. Of course, carboplatin we have been using for a very long time, so we know how to manage the toxicity of carboplatin. Nevertheless, the protocol also had an amendment. They reduced the dose from AUC 2 to AUC 1.5. But toxicity remains a concern. So PathCR is better, but toxicity also is a concern, especially if you are looking at an elderly patient with comorbidities, may be a concern. The benefit was confined to TNBC subset, which is the topic of discussion, and the benefit was irrespective of the BRCA status. The idea is that it's a commonly used drug, economical drug, toxicity is known, essentially preventable, so worth adding carboplatin. This is what I feel while we are looking at a young triple negative breast cancer today. About PARP inhibitors, the brightness study. This study had randomized over 600 patients to paclitaxel carboplatin with veliparib. The second arm had paclitaxel carboplatin and veliparib was a placebo. And the third arm had only paclitaxel and carbo and veliparib were placebos. And then after 12 doses, they were sequentially given anthracyclines, the standard AC regime. And then primary endpoint was, of course, pathological complete response rate, EFS, OS, and safety. Surprisingly, people thought that the new drug will have some additional benefit. The new drug did not have any additional benefit. The PathCR rate with the addition of veliparib was no superior to plain pacli-carbo alone. Again, there was a update stratified analysis of EFS with the median follow-up of 4.5 years. You see the top 2 lines, they represent paclitaxel carbo veliparib. the red line, and the yellow line is paclitaxel carboplatin, almost overlapping, almost a single line, and alone paclitaxel was definitely inferior. So the benefit of veliparib was not seen. The benefit was seen with better response. So you had a better response, better pathological complete response. The EFS was better. That was the truth, whether you added veliparib or whether you added carboplatin. So whether you had germline BRCA mutation, you did not have germline BRCA mutation. If you achieved a pathological complete response, you are going to do better. So probably the addition of carboplatin improved survival and not veliparib. PathCR was better in the BRCA wild type subtype. Of course, the number of germline BRCA mutation was less than 20%, and the event-free survival correlate with the pathological complete response rate, not the BRCA status. Immunotherapy, this molecule is trying to make its presence felt in almost everything. So why not in triple negative, the low-hanging fruit where there is no biological, no good biomarker to treat. So these were patients who were newly diagnosed triple negative breast cancers, either T1C or node positive disease, or T2 to T4 disease, which were node positive or negative, good performance status. These patients were, remember, all comers were given. It was not related to only PD-L1 positive or PD-L1 negative. All comers were taken. Nevertheless, about 80-85% of the patients were PD-L1 positive. Patients were first given carboplatin paclitaxel with pembrolizumab 200 milligram flat dose, and then sequential anthracyclines and cyclophosphamide. So complete neoadjuvant chemotherapy for 24 weeks, and the other arm received the same chemotherapy without pembrolizumab, only the placebo. And then in the adjuvant setting, the pembrolizumab group was continued on pembrolizumab for additional 27 weeks. So about a year's treatment was given, treatment of pembrolizumab was given. Pathological complete response was the primary endpoint, and at the first interim analysis, it was significantly superior in the arm which received pembrolizumab. The green bar represents pembrolizumab arm, 64.8%. So we were looking at 30 to 40%. Now we've almost jumped double. 64.8% was the PathCR. Remember, the control arm didn't do badly. Control arm also had a 50% of pathological complete response rate, which is interesting to note. Probably the benefit of giving the complete neoadjuvant chemotherapy before surgery. And the first TFS analysis showed that there was definite improvement with the addition of pembrolizumab, 91.3% versus 85.3%. Again, this continued to remain, the curves continue to separate even numerically and statistically. They were significant. This was at the interim analysis 4. So 84.5% versus 76%. And that was at a median follow-up of almost 40 months. Overall survival, well, statistically just achieving significance. Numerically, not so. 89.7, 86.9. I don't know why. Maybe at a later date, they had some other issues, and that is why this arm did not do significantly better, or something earth-shaking difference was not seen. The important aspect of adding pembrolizumab is not the other aspects of toxicity, because nausea, vomiting, or hematologic toxicities are anyway expected to be less, but the endocrine toxicities are noteworthy. That these patients had hyperthyroidism, sometimes even severe skin reactions, adrenal insufficiency, transaminitis. These were toxicities unique to the addition of pembrolizumab, and they need to be considered. Not today, but in the next few years to come, we are going to have generic immunotherapy as well, and then we are going to have a lot of these patients, and we better be prepared for these kind of toxicities in the later years to come. So remember, pembrolizumab was given to all comers. The magnitude of response was better in PD-L1 positive patients, but the number of PD-L1 negative patients were very few, less than 20%. Remember, pathological complete response rate was good even in the control arm. So the overall survival was not very impressive, but nevertheless, some numerical advantage of giving pembrolizumab seen in the overall survival. So to conclude my talk, neoadjuvant chemotherapy in triple negative, we are now moving more and more towards early neoadjuvant chemotherapy in earlier tumors, not only in those large fungating ulcerated tumors, but even tumors a little over 2 centimeters or single node positive disease. And it will probably improve our results. We do not have any good biomarker to select patients for neoadjuvant chemotherapy. Addition of carboplatin has improved pathological complete response rate, but that comes at a cost of increased toxicity. It may be a good choice for a young, fit patient who desires breast conservation. Probably it's a poor man's PARP inhibitor, poor woman's PARP inhibitor, or something like that. And once we have better access to immunotherapy, probably it's going to be a standard frontline therapy. Thank you.
Thank you, sir.